Good morning. This is Healthlines, and I'm your host, Liza Marron. Healthlines is a talk show dedicated to sharing helpful information about different health topics and health organizations present in the Upper Rio Grande Valley. Healthlines is produced by KRZA and Valleywide Health Systems. Valleywide Health Systems operates family practice and dental clinics throughout the San Luis Valley. So today on Healthlines, our conversation is focused on the opioid epidemic and strategies that are being implemented in our community to combat the problem, especially at SLV Health. So this morning in our studio, I'm really happy to have San Luis Valley Regional Medical Center ED Medical Director Megan Koenig, and the Regional Medical Center Emergency Department Nursing Director Monica Hinds. So good morning.
Good morning. Thank you for having us.
Yeah, thanks for coming in. So could you tell our listeners a little bit about yourselves and how you got into the medical profession?
Sure. My name is Dr. Megan Koenig. I'm originally from South Denver, but currently live in Colorado Springs, as my husband is active duty Air Force, so we're stationed at the academy there. So I commute to Alamosa regularly and have been the ED medical director here for about 2 years now. I got into emergency medicine because I just loved the diversity of the field. We deal with anything from a cut on your finger to a massive heart attack, and I just love that. I'm passionate about everything in between there. I've trained all over the U.S., from Arizona to Chicago to Washington, D.C., but Colorado is where home is, and so that's where we've landed.
Awesome, thank you. All right, Monica.
My name is Monica Hinds. I'm not originally from the Valley, but I've been here for about 25 years, so I do consider myself a native of Alamosa. I've worked in the hospital for over 4 years. I've been the emergency director of emergency services for a little over 7 months. I was looking for a career change when I was pregnant with my first child, and because of all the wonderful medical care that I received at SLV Health from my OBGYN and all the nurses, made me want to pursue a nursing career. So I went ahead and enrolled into Trinidad State Junior College here in town and got my ADN. And later on, 2 years after that, I received my bachelor's online, and now I'm the director of the emergency department.
Well, that's great, and we're so happy to have you both because we know that it's really important to have good professionals in the medical care in rural Colorado. So thank you so much for what you do. So can you share the meaning behind your suffixes for a minute? There's a lot of them there, and so especially with you, Dr. Koenig.
A little bit of alphabet soup at the end, but the DO just stands for Doctor of Osteopathy, so that is the equivalent of MD. We just get a little extra training in osteopathic manipulative medicine. The MBA is my Master's in Business Administration and Healthcare Leadership. And then the FACOEP is just the Fellow of the Academy, or the American College of Osteopathic Emergency Physicians. So those are the letters behind my name.
Okay, well, you're qualified. And how about you?
So as I stated, I was an ADN, I got an associate's degree in nursing at TSJC, went back and got my bachelor's, which is my BSN, which is Bachelor's in Nursing, Science of Nursing.
Okay. All right, so we're going to dig into the opioid conversation, and probably every listener out there has been touched by the growing opioid crisis in our nation. So can you address maybe the history of this problem and how it's come to the forefront?
Well, historically, we've been using the opium poppy plant for over 5,000 years to treat pain. So it was quickly apparent that it was very effective pain medication, but also very addictive. So then throughout time, morphine was developed to deal with the opium addiction, then heroin was developed to deal with the morphine addiction, and then methadone was developed to deal with the heroin addiction. Whoa. And so you can basically see this quite repetitive cycle where we just replace one strong abusive substance with another, thinking we're sort of treating the problem, but we're obviously not. So more recently, in 2000, pain became the fifth vital sign, which subsequently tied pain management to pain satisfaction, which sort of started the trend. From 2006 to 2015, U.S. pharmaceutical companies spent $880 million on advertising of opiate pain medications, making opiates basically become the go-to drugs for not only patients but also physicians. So fast forward to today, where a third of the population of the U.S. has been prescribed an opiate. The U.S. consumes 80% of the world's supply of opiates, even though we only account for 10% of all the people. Every single day, 78 people die of overdose, which now makes overdose the leading cause of death in our country. So, I mean, if those numbers don't speak to our problem, that's, and we all know our valley is definitely one of the most affected, especially in our state, so.
Thank you for that, Megan. And I'm just curious, what are the inherent qualities of opioids that make it so addictive?
Well, opioids create artificial endorphins in your brain, so this gives you that positive feeling, that rush. But over time, these opioids trick your brain into stopping production of those endorphins naturally. So at this point, the only way for an addict to feel warm and fuzzy inside again is to continue to use the drug. So therefore, you stop using the drug, you start to feel sick and depressed. So it becomes this vicious cycle of constantly trying to seek out that happiness and that warmth. This is why we found such a strong link to psych illness, as the way it makes you feel seems to fill a void in your life that you may have been missing all along. So you become psychologically addicted to the way it makes you feel, as well as chemically addicted.
All right, that's really fascinating to understand. And what are you actually seeing with patients relating to opioids at SLV Health? And I'd like to ask that to both of you.
Well, so pain is obviously the most common complaint we see in the emergency department. Abdominal pain, chest pain. Almost every person that comes into the ED has some component of pain. So our ED docs and nurses are definitely on the front line of this opioid epidemic. We see firsthand the effects that addiction has on our patients' health and demeanor. Unfortunately, I think the stigma and shame associated with drug addiction has driven many of our patients away from healthcare and into the underground world of street trading, dealing, drug abuse. So often we will see them at the worst, an overdose, or at their lowest of substance abuse and withdrawal, or seeking prescriptions. So we at SLV Health are doing all that we can to change that perception so that our patients who are at highest risk for infection and death have a safe place to turn where they don't feel judged and uncared for.
Oh, that's really wonderful. And how have you been seeing this expressed?
So I agree with everything that Megan has said as well. But in order for us to properly take care of our patients, we as nursing have to ask those difficult questions to patients and to every patient that walks in the door, to make sure that we're understanding how to properly care for them. We get many different reactions from our patients, from laughter to amazement to even hostility when we ask those questions. As a department, we see so many different types of people, medical conditions, and we do want to do the best for our patients. And if that is sitting them down and educating them on addiction and drug use, then that is what we're going to do to make sure that we're making sure that our patients are safe.
Okay, well, that's a hard conversation to have sometimes, it sounds like. So it sounds like you have we're really excited to talk about the strategies that you're coming up with at SLV Health to counter this problem. Can you talk about that?
Of course, yeah, we're very excited about all the strategies going on in the Valley in general. But so for all of 2017, we had been watching from the periphery and anxiously awaiting results of the Colorado Hospital Association's Alternative to Opioids pilot project, also known as the Alto project. In January of 2018, Monica and I both went to a conference that was held in Denver to release the results of their study, along with several other of our nurses. Their goal was to decrease opioid prescribing by 15%, but actually found that 10 hospitals that participated actually decreased by more than 31% on average. So this was obviously exciting for us to hear and to have an option to bring back to the Valley in hopes that we could actually see results here as well. So our mission with this Alto project at SLV was to help to basically first break our own addiction to prescribing opiates by educating our providers on all the alternatives to opiates that are available. This has been a multidisciplinary training approach, which has included administration, pharmacy, IT, anesthesia, respiratory techs, nurses, HPs, and physicians. So we've had to update hospital policies, purchase new equipment and medications, attend specialized training, and more. Knowing full well that just decreasing what we are prescribing from our ED isn't going to solve the epidemic, we did create a packet of resources of all the substance abuse resources that exist in our valley and even statewide so that our impact extends beyond discharge from our facility.
Okay, and that's a lot of staff because you are the largest employer in Alamosa County, I think, maybe even in the San Luis Valley, from the statistics I've seen. So how was this designed? How was this program designed?
We have to give credit basically to CHA and the Colorado ACEP, the American College of Emergency Physicians, because they designed this whole process for us. And at that conference we went to in January, they handed us packets of exactly how to make this happen. They had packets for your ED director, for your ED nursing director, for your pharmacist. I mean, they really couldn't have made it easier for us and have been very helpful. Whenever we had questions, we have a point of contact who we can get in touch with. And if they don't know the answer, they've helped us with the answer. They've sent people out here to help us train. So between that and our administration here locally, just being completely open to doing this and supportive, it has been very easy on Monica and I.
Okay, and how is it playing out in the emergency room and with primary care visits? You kind of have different strategies for that, it looks like.
So here at the hospital, the primary care clinics have implemented numerous things as well, including pain management agreements to hold patients accountable, education on some protocols which are for brief interventions, treatment, drug abuse screening tests, which help us to determine which patients are at high risk for addiction. Use of the Colorado Prescription Drug Monitoring Program that cross-checks to make sure that no other providers are writing prescriptions for their patients. Referral process to medication-assisted treatment options, osteopathic manipulation by providers, as well as social support, care coordination, and other mental health resources.
Can you mention a few of the indicators of somebody who might be at high risk for addiction? What does that look like?
There's multiple. If I guess number one being, are they on any other pain medications? Are they on any other antipsychotics or antidepressants, other benzos, any other medications that could sort of easily lead to overdose by combining the two? Number two is any psych history. If you've got any history of anxiety, depression, and very important is PTSD, any childhood trauma, any sexual trauma. And so this goes back to what Monica was saying about it's an awkward conversation, and it is, people will laugh at you. And we just feel we have to have that conversation though, because we really have to reduce that stigma, make it a natural point of conversation.
Yeah. Okay, because I'm like that person who opens a bag of chips and pretty soon I ate the whole thing and I'm like, okay, well, don't give me something stronger. So, so let's talk about, how this is being implemented on the ground here at SLV Health.
Well, I think there's a misconception that this new project means we are no longer treating pain. So please rest assured as patients, this is not the case. Instead, think of it as that we now have more tools in our tool belt to help address your pain. None of these are new medications. They have all been around for years and have been proven safe and very effective. It was just reminding ourselves that they exist, and in some instances, actually buying new equipment and medications to better stock our facility. So rather than reflexively giving every single patient the exact same medication, we are now actually taking their complaint into mind and disease process into mind and deciding upon a non-addictive medication that actually treats that specific pain. So there's visceral type pain, if there's belly pain that responds totally different than a muscle pain might. So using two different medications to approach those. So as a physician, I actually feel like I'm better prepared to treat your pain now with this Alto project than I was even a year ago.
Excellent. And what about, I imagine that you have different kinds of patients walking in the door, some who are really experiencing significant pain and are there for a first time experience, and somebody else who might be addicted and be looking for ways to get a new script. And how do you deal with those decisions?
It's difficult. As we've alluded to, these conversations aren't easy, but I think the most important thing to do is sit down and listen to their complaint. Often I think in the ER we're very quick to just jump to what we think they're there for because we're just quick people in our minds and trying to get to the emergent reason. But sometimes, especially in these patients, you really need to sit down, listen to their complaint, acknowledge their pain, directly address the fact that you want to help them with their pain, but that you want to do it in the safest and most effective way that doesn't lead to adverse effects such as long-term addiction.
Okay, and how do you help the addicted?
This can be a very difficult task in the ED. Often you're meeting a person for the first time under a very stressful situation, and you may never even see them again. So you have a very limited amount of time to know them, gain their trust, earn their respect from them, while also diagnosing and treating the medical condition that they presented for. So we do our best to be a safe, judgment-free place where they can be vulnerable and seek help. And I think that's, you just have to wait for an addict to be ready to seek help. And we just need to be there, the open ears when they are ready to get that help.
Okay. So what are the best tools you have in your toolbox for opioid alternatives when people present with pain?
I honestly think that as the physician, the best tool that the Alto protocol has provided our team really has little to do with the individual medications themselves. We've known about all of those for a long time. It was just sort of reminding us of those. But it's more to do with how we treat our patients. It reminds us that a drug addict should not be judged or shamed. We have learned that it is just as important to ask them about their mental health history, as we discussed before, childhood trauma, family history of substance abuse, as it is to ask the more typical questions like what surgery you've had, what are your allergies. We need to stop treating mental illness and substance abuse like it is an uncomfortable topic that should just be brushed under the rug and not discussed, or one that a patient should be embarrassed to share. A patient should feel very comfortable opening up to me about this as much as they are their diabetes or their hypertension. And I think this is the only way to sort of help an addict get going in the right direction.
And if somebody is, experiencing addiction and they open up to you, it's a safe environment. They don't have to worry about law enforcement being called into the picture. Is that the case?
Correct. As long as law enforcement did not bring them in, as long as arrest was not the reason they were brought to our ED, we never call to get police involved regularly. We do have a duty to protect. So if we feel that you are a threat to yourself or others, then we may get mental health involved, but it is very rare that we get police involved as long as everyone's cooperative and we don't feel there is a threat to safety. So in the majority of situations where you're just sitting having a discussion and someone opens up to you about drug abuse and it's a very respectful conversation back and forth, there's no risk of us calling cops or telling them that you do drugs, or we really try to protect privacy in that regard.
All right, and you talked earlier when you were talking about the history of this opioid crisis. We talked about heroin, and that's more of the street version. I know there's prescriptions out there on the street as well, but what do you see at SLV Health in the emergency room, and how is heroin involved in?
As we discussed earlier, I think heroin was brought into the picture obviously to replace morphine addiction and opiate addictions. As sort of a supplement on the street. So my personal experience is that as the opiate prescriptions became harder to come by from physicians, as we started being cracked down on the prescriptions and the number of days we could write and the length, then the street value of each pill of a narcotic went through the roof, which then drove patients who couldn't afford the pills to turn to much cheaper options, which was heroin. And so you definitely see quite a bit of heroin in our community. In all communities in the U.S., but we definitely feel it very hard in the Valley here.
Okay, so is there a situation when opioids are indicated?
So from the nursing standpoint, there is definitely times where opioids are needed. We do try to do the Alto medications first, to see if those assist, because sometimes those are all the patient needs, and we don't want to take that chance of adding something in that a patient can become addicted to. So we make sure that the opioid is definitely not our first thought. But if the pain continues and that's something that we need, then we will definitely let the provider know that the patient does need something a little bit stronger than the Alto medications that were given to them.
And I'm curious, when a person presents and you ask them on a scale of 1 to 10, where's your pain? Is it important to get somebody to 0, or are you just trying to get a person down the scale a bit?
That's a great question. So, we're not looking at removing everybody's pain completely. We do want to make them feel more comfortable, but with everybody's understanding that when you come to the emergency department, we're going to reduce that pain, but not eliminate it.
Okay.
I think that's one of the things that the Colorado Hospital Association really did well, helping train us to train our teams. Was a huge portion of this is wording and how to educate the patient and sort of scripting our words to try to teach the patient what we're trying to do. So in part of this, they basically said from the get-go, tell them the goals so they know that they're not supposed to get down to a 0. So having that conversation of, my goal is to get you comfortable enough that you can go home, be comfortable, go to sleep, eat some food. I'm not going to be able to get you pain-free. And it's amazing having those conversations now where you say, you have a rib fracture. This pain is not going to go away for 6 weeks. So don't expect to be pain-free, but I want you breathing good. I want you having deep breaths. And once you educate them of the expectations, we've seen quite a difference in their expectations because they don't expect us to get them down to a 0, because there's no way short of me putting you to sleep in a broken bone that I'm ever going to take your complete pain away.
Right. We don't come to the emergency room to go to sleep. So, do you what maybe alternative therapies like acupuncture and chiropractic, does that come into play in things that you help patients with?
Of course, and I actually have my master's in complementary and alternative medicine, so this is sort of a topic that's very dear to my heart, and I very much believe in all of the Eastern medicine approaches. The problem is that we live in a society that is Western medicine based, and so we often, as providers, look for something that is effective and research based before we can safely recommend it to patients. So I think those tend to be the protocols and the therapies that are first thrown at you from physicians, because that is just what is ingrained in us in this culture. But I have found that even if research doesn't exist, if a patient believes in the power of something, there is incredible power in that, whether we have a good study to prove it or not. And I've seen great relief with massage therapy and OMM from a DO, acupuncture, chiropractors. I'm on almost every one of my motor vehicle accidents. My first thing I tell them is you need to go see a chiropractor or massage therapist tomorrow because you're going to hurt so much worse. And just the pain meds I'm going to give you are just going to mask the pain. This person is actually going to help treat the pain. And so there's offering them multiple modalities rather than just the pain medication.
That's a great approach. Do you address root causes such as PTSD and childhood trauma that addicts find opioids relieve unbearable symptoms for them? I know you're in the ER, so. Yeah,
and I think as we alluded to before, and maybe with the help of this Alto project, it's reminded us to do that, because part of the education in this was looking at the substance abuse risk factors. And before writing an opiate, even if you got to that point that we did decide this is an appropriate thing to use an opiate on, before prescribing, talking to them about their risk factors, educating them on the addiction potential, because we used to just prescribe these without actually talking to them and saying, hey, one pill can get you addicted. So please use these sparingly. If you have addiction potential, I actually want to avoid them. Maybe try something different. And again, having those very difficult conversations.
Okay. Monica, I'm curious, you talked earlier about the outpatient patient pain agreement. What is that?
So this is a written and signed document that outlines the duties and expectations of both the physician and the patient when a controlled substance is prescribed to them. This includes such points as treating each other with respect, not missing scheduled appointments, taking the medications as prescribed, definitely not sharing the medications with others or family members, and then not using the ED as a source for their refills.
Okay, and do people generally respect that agreement? Do you find it to be a positive tool?
We do find it. We do have those patients, though, that do come in and break their pain contract trying to find that prescription refill because they didn't use their medications the way that they were prescribed, or they could be doing other things with them as well.
Okay. All right. So I was curious, is there a connected system so patients can't go to multiple doctors?
There is actually a statewide connected system. So each physician has access to an internet resource called the Colorado Prescription Drug Monitoring Program, which allows you to look up multiple details on each patient. You can see which providers have written prescriptions for them and in what quantities, what pharmacies they've filled it at, what addresses and aliases they may have used. So it's a very helpful tool when you are possibly questioning if someone has had multiple prescriptions in the past and you're just wanting to make sure you're not going to overdose them.
Okay. And is there a non-addictive pain medication for number 10 pain?
You mean like 10 out of 10 pain, I assume, like the highest level of pain that comes into the ED? Yes, and actually, you should see the amazement then in some of our providers' eyes just in some of these things that the Alto protocols have provided us. We've really seen incredible relief in pain from a lot of the alternative medications that have been provided to us. The key is that you're selecting the medication that's directly effective for the complaint and condition at hand, kind of like I was talking to you about before. So if you have a bone pain or a fracture or a rib fracture, there's certain medications that truly treat that specific type of pain, which is a totally different pain pathway than, say, chronic pain or abdominal pain with acute appendicitis. So instead of just willy-nilly throwing the exact same medication at every person with pain that comes through the door, it's sort of taking a step back, thinking about their pain pathway, and giving them the right medication. And it's kind of interesting to see when we're giving the right medication, it's actually helping their pain more than the opiates did, really.
All right, so this has multiple blessings, this approach that you're taking. Mm-hmm. And then also, I was curious, you have this big staff. How are you getting this education, and how are they receiving these new, protocols?
Yeah, education is definitely a huge priority to us as it relates directly to our patient safety. The Alto program was released in January, but we didn't go live until May to make sure that we had all of our staff properly trained prior to administering these medications in ways that they're not used to. This started from the ground up. We like Megan said, we had herself and we went to a conference in Denver where they specialized in the training for these. The leaders were educated on from various departments. We also created many resources, such as teaching guides, quizzes on the medication policy to help guide the administration of the more complicated drugs, and there again, the routes where they're not used to giving them. Today, we continue to adapt our processes, educate accordingly as we run into issues or any kind of roadblocks. There again, Colorado Hospital Association was huge in training our staff. They brought many of their staff members down, did a train the trainer course for us as far as with nursing and providers, data, pharmacy, basically organizational wide to make sure that we all understood how this project was going to work and be effective for our staff themselves and for the patients that we care for.
Okay, thank you for that. So what community resources, our listeners, might you have out there for families maybe who are concerned about a loved one, or somebody who's listening and just would like to reach out and get some help?
I think with Monica and I sort of taking this project on, we learned about a lot that was going on in the community that we had no idea. We were sort of in our bubble in the ER. And so one of the first things we did was bring together a big group of all the community leaders that had resources, and we learned a lot. And so we learned that SLV Health and Valleywide both have providers who prescribe Suboxone. In fact, Valleywide is trying to staff each of their clinics with a Suboxone provider. Crossroads provides methadone for patients with PCP referral. Community Corrections provides substance abuse resources by court order. The SHARP program is a free clinic that provides needle exchange programs. So there are numerous programs. If you are interested at all, we have a packet of resources. You do not need to be an ED patient. You can just stop by and ask for the packet of resources, and we will provide you one.
All right, we may have to do part 2 because this is a fascinating topic and we are at the end of our time. So you've been listening to Health Lines. I'm your host, Liza Marron. Thank you for tuning in.